Now I'm going to go over some gas exchange things, some more things for gas exchange. So with artificial airways, we know we have different types of artificial airways. We have those oral airways. We know it's the simplest type of artificial airway, prevents obstruction of the trachea by displacing the tongue and the oral pharynx. Oral way extends from the teeth to the oral pharynx, maintaining the tongue correct position, but you got to have the good size. We also have endotracheal tubes. It's a short-term artificial airway to administer invasive mechanical ventilation, relieve upper airway obstruction, protect against aspiration, and clear secretions. Usually removed within 14 days, but they may be in longer. And then we have, last but not least, a tracheostomy. So it's like a surgical incision into the inferior border of the cricoid cartilage of the trachea. A short tracheostomy tubes inserted. They usually have a small inner tube that fits inside a larger one. And the most common complication of tracheostomy tube is partial or total airway obstruction caused by buildup of respiratory secretions. Next, we look at suctioning. We're going to use a Yonker or tonsillar tip device. This is this thing right here on the left. There are some risk factors when it comes to suctioning, so like they have an impaired cough, a gag reflex, or weak respiratory muscle, decreased LOC. These would be risk factors. We also have to assess when suctioning for signs of hypoxia. So if they're anxious, their LOC changes, their vital signs changes, their oxygen changes. So if you're hearing vintage sounds, I would not do suctioning. And if you do get hypoxic as you're doing the suctioning or anything goes wrong, make sure you have oxygen available because you're going to need it quickly. So when you do suction, you want to make sure you go for the cheek pockets, never straight down the throat. Then on infants, you'll use bulb suctioning to make sure to fully depress the bulb after putting it in the mouth. So NAPs won't do it suctioning until after respiratory status. After they assess respiratory status, if their respiratory status is good, then NAPs can go ahead and start suctioning. We also have to control secretions in patients. We can do this by increasing oral liquid intake. This will thin the secretions. If we get them to cough and deep breathe, that will break up the secretions. We also use chest physiotherapy. So it's like postural drainage, chest percussion, and vibration. It's usually by respiratory therapy. Next, we have non-invasive ventilation. This is used to prevent a mechanical invasive ventilation. We don't want to go invasive, but because it's like more expensive and it's kind of more complications, stuff like that, but we will if you do. But this prevents having to go very invasive. So this uses positive pressure airway to keep the airway open. It's good for preventing or treating atelectasis. And if you remember, atelectasis craps the alveoli, reduces pulmonary edema by pushing fluids back into the circulatory system, and improves oxygenation with sleep apnea. So sleep apnea, pulmonary edema, and atelectasis are the three main disorders that are going to be really good for non-invasive ventilation. Okay. Next, we have incentive spirometry. I like seeing these things. I've seen these a lot in the hospital. Assist with deep breathing. It's visual feedback for long, deep breaths. And NAPs can do this, but it's independent nursing intervention, so they may need to pay for it. A good recommendation for the amount of times they should do it is every hour they're awake, roughly do about 5 to 10 breaths per hour. Now let's get on to oxygen administration. So we know oxygen is a medication, so therefore, since it's a med, you have to have a physician that orders it to continue taking it. So there are multiple ways to administer it: the nasal cannula, the Venturi mask, the 100% non-rebreather, the simple face mask, and the partial rebreather. You can delegate oxygen administration to any application, may be delegated to oxygen administration, may be delegated to NAP. Assessment and order are in responsibility. NAP may not administer oxygen to someone with artificial airway. You have to know the fire safety education with that too. If we can show, I'll show you. Remember, these safety precautions are read down here. You can read these if you want, but these are the precautions you gotta know, like oxygen use safety if you're at home, no smoking at home, stuff like that. Chapstick stuff, keep that away. So these are the delivery rates. We talked about these earlier. You can read these. So nasal cannula is how many liters per minute? 1 to 6 at what percentage? 24 to 44. The oxidizer is how many liters per minute? 8 at what percentage? Up to 30 to 60%. The simple face mask is how many liters per minute? 6 to 12 at what percentage? 35 to 50. The partial non-rebreather is how many liters per minute? 10 to 15 at what percentage? 60 to 90. The Venturi mask is how many liters per minute? 4 to 12 at what percentage? 24 to 50. The high flow nasal cannula, well, that's like the 60 liters. All right. So we have sputum cultures. We get this by suctioning into a sterile suction trap or having patient cough and expirate into a sterile cup. And NAPs can do this. And before we do it, do not allow the patient to use toothpaste or mouthwash prior. So what you do is have them take 3 to 4 slow breaths with exhalation. And then they'll do a full inspiration followed by a forcible cough. So they'll breathe in and then breathe out all slowly. And then they'll take a full inspiration as far as they can and cough. You want to get 5 to 10 milliliters of sputum, not saliva. Then we have TB stuff, 3 consecutive morning cultures should be attained, stuff like that, we know that. Then we have peak flow meters. These measure peak expiratory flow for patients with asthma or reactive airway disease. Proper use can identify an exacerbation before clinical signs appear. So that's pretty cool. So if there's any problems, you can identify, oh, something's about to happen. But you have to educate really well on these and provide an assessment. So initially cannot be delegated, but may delegate the task for a stable client. So with the meter dose inhaler, it's actually medication, so you can't delegate it. Patient education must be done with this, and many times spacers are used to facilitate proper inhalation. And then we get to a nebulizer. Remember, some medication, so you can't delegate it, but this adds moisture to medication, which helps in loosening secretions. So then we get to catheter, which is inserted into thorax to remove air or fluids from the pleural space, permit air or fluids to re-entering the pleural space, or reestablish normal thoracic pressures. And you got like pneumothorax, which is air in the lungs, or hemothorax, which is blood in the chest, I think, or lungs, maybe. So the chest tubes keep system closed at all times, and below the chest, you want to monitor for any bubbling in the system, and water level should fluctuate with each breath. Measure the drainage of each shift, and encourage turn, cough, deep breathing, center spirometry.